This was the task that I was given to talk about the diagnostic approaches, be it ERCP, cholangioscopy, or EUS. Basically, this talk is about tissue acquisition. We can talk about cholangiography, we can talk about many different aspects of things, but in terms of making a diagnosis for cholangiocarcinoma, it is a tissue diagnosis. So this talk will concentrate on ERCP and its ability to obtain tissue, ERCP plus cholangioscopy, and endoscopic ultrasound. So there are basically two sampling techniques that have prevailed with ERCP. One, and the simplest, is brush cytology, and the second is fluoroscopically guided biopsies. And this is a compilation of many studies that show that the overall cancer detection rate for brush cytology is somewhere around 60%. But I would point out to you that it's actually, these studies have been done quite a while ago. So it's interesting that ERCP, which is still a very, very standard technique, and brush cytology are not talked about, or at least written about very much anymore. The second way is fluoroscopically guided biopsies. This, again, is a compilation of studies, some of them more recent than we saw with brush cytology, but again, about a 60% sensitivity rate or cancer detection rate for guided biopsies, fluoroscopically guided biopsies. Clearly results that need to be improved upon. And there are a number of problems for tissue acquisition during for cholangiocarcinoma. Certainly one is inadequate contact with the cancer. So we don't always know if the biopsies are in the right position or if the brush is in the right position when you're doing the tissue sampling. Also, cholangiocarcinoma can have a very strong desmoplastic reaction. The tumors can be very firm, and the cancer cells can be very sparse, only scattered throughout a dense fibrotic surrounding area. Secondly, there can also be submucosal spread, and obviously if there's submucosal spread and you end up targeting that with the brush or biopsy, you're unlikely to get a positive sample. And then finally, we don't really know, but I think in general practice, we probably obtain too few biopsy samples. So how can this be improved upon? We've had a long time to improve upon it, but nothing has been certainly perfected. For brush cytology, there have been reports about disrupting the wall of the bile duct through dilation, either a balloon dilation or a step dilation. There are some new brushes out there. US endoscopy presents a larger brush and one with a stiffer brush. And some early studies have shown that this may be helpful, but it's a very stiff system, and so access may be a problem with this. I think aspirating bile has been tried. It's certainly something that you can augment for your brush cytology, to aspirate bile after you've done the brushing. And then finally, you can submit an indwelling stent. So if a patient has an indeterminate stricture, there are some studies that suggest that if you harvest cells from a stent that has just been removed, particularly around the area of the flaps, then you may be able to gain some information cytologically. From a biopsy standpoint, we don't know what the optimal number is. It probably is at least 3 or more. You can use swivel tip biopsies to try to get a better perpendicular angle to the bile duct. Part of the problem with biopsies is you're always working tangentially, so the biopsies are scraping like this rather than in the esophagus where we try to get perpendicular. There is a thing called a SMASH protocol that has been tried. Basically, you take a biopsy specimen and you smash it on a slide, trying to get a monolayer of cells. One study has shown that it's got about a 72% sensitivity for this SMASH technique. And then there is ROSE, rapid on-site examination, and I'll talk about that in just a little while. There are multi-modality techniques, so if one is not particularly sensitive or several of them are not individually particularly sensitive, then it may be worthwhile to do multimodal sampling. And the study that I quote here from Ananda in 2015 used brush cytology, biopsies, and FISH. And they went from an individual sample having a sensitivity of 27 to 59% to an overall sensitivity of 82%. So multimodality sampling is probably a good thing to do. And then there are non-sampling techniques, FISH and confocal laser endomicroscopy, which may help in making a diagnosis with ERCP. We then have cholangioscopy, and I don't have time to go through all of the different cholangioscopes. Dr. Moon has covered that to a certain extent. Basically, the single operator system marketed by Boston Scientific is the one that is used most now. This has very, very, very good functionality. So it's got a suction port, so you can aspirate from the bile duct. It's got four-way tip deflection, which is really pretty good tip deflection, and then a separate channel for water infusion. So the functionality of this particular instrument is superb. And secondly, it's quite easy to set up. So it takes maybe about 3 minutes to plug it in. You hook up the two connectors here, one for suction and one for water infusion, plug it into the processor, and you're ready to go. And it's quite easy to use. So here's a case of a single operator cholangioscopy, a 57-year-old with alcoholic cirrhosis and portal vein thrombosis, admitted with worsening jaundice, and the lab showed a bilirubin of 27 and alkaline phosphatase of 299, and the question was whether or not this was hepatic or bile duct. And you can see here a clear demarcation on cholangioscopy between the normal sort of pearly type of biliary epithelium and then this neovascularization, these dilated, kinky blood vessels that we associate with cholangiocarcinoma. So both, number one, we get a visual sign, and even visually, this would have a pretty high sensitivity and specificity for being a cancer. But with this instrument, we can also do biopsies, and you can see here the biopsy port now comes out regularly at the 6 o'clock position. You can advance the biopsy forceps. In this case, I got pretty perpendicular to the bile duct wall, and so it's a very, very good way to sample. So that's cholangioscopy, and this biopsy indeed showed cholangiocarcinoma. So this is a study by Osani published in 2013, and basically it was looking at the diagnosis of cholangiocarcinoma, and he compared ERCP alone to ERCP plus cholangioscopy, so just ERCP plus pure visualization, and then compared that to ERCP plus cholangioscopy visualization plus cholangioscopy guided biopsies. And you can see here it's similar to multimodal sampling. With ERC alone, you've got a sensitivity of about 35%. If you add the visualization of cholangioscopy, you go up quite a bit, but you get the maximal impact with cholangioscopy-guided biopsies. So again, a study that suggests that cholangioscopy is better than ERCP alone. This is a study from Peter Dragunov at the University of Florida, and he looked at comparing brush cytology to blind biopsies to cholangioscopy-guided biopsies. And again, for brush cytology, his sensitivity was really quite low, well below the standard. I don't know quite why it was so low. Blind biopsies were at 30%, and then a single operator, when he added that, we got up to 77% for cholangioskopy-guided biopsies. So I think, obviously, we are making progress when we add cholangioscopy to ERCP. We have done a lot of work with EUS-guided tissue acquisition, and one of the things that we have published on quite a bit is ROSE, so rapid on-site cytopathology. And so we investigated the possibility of doing what we call wet preps. So it's basically taking a biopsy, and as you can see here on this protocol, we take some special tweezers, and we just move the sample across the slide to exfoliate some of the cells from the biopsy onto a slide. We then put the remainder of the biopsy into formalin, and it's studied formally as you would with any other biopsy. And then we use a typical cytologic stain to look at the sample in real time in the room. And that's what we call Rose TIC, so Rose TIC. And here you can see on the top part of the slide is the touch prep that we've gotten from one of these bile duct biopsies, and on the bottom is the biopsy itself after it's been put in formalin. So on the far left of the slide here is a meta-analysis, systematic review done by my partner Uday Navanithan, looking at the sensitivity and specificity of brush and biopsy. And you can see here that brush cytology in this meta-analysis was 45%, and with biopsies it was 48% with a very high specificity. When we did SPY without in-room cytopathology, so without rows, but we did directed biopsies rather than blind biopsies, our sensitivity went up to 60%, with a specificity of 98%. And this was published in GIE by Uday Navanithan. We then took that a step further and we did SPY biopsies. So we did single operator directed biopsies, but then we did rows. And we found that the sensitivity was obviously exceedingly good with this technique. So we do a biopsy, we get an immediate read on that biopsy, we can do another biopsy, get an immediate read, and with that, we got 100% sensitivity for cholangioscopy-guided biopsies using rapid on-site evaluation, and that was published in GIE in 2016 by our group. The algorithm, however, that we have followed based upon the data that you've seen is basically EUS first. So when we get an obstructive jaundice patient, we will do EUS first. And by this algorithm, if we do not see a mass on EUS, then obviously we will proceed to ERCP, and if it's a proximal stricture, then we will do cholangioscopy, guided biopsies. In our unit, we will do rows. On the other hand, if we see a mass on EUS, then we will do EUS-guided FNA. So that's the algorithm that we would normally use. Here's a proximal stricture, and here's a distal bile duct stricture. This was obtained by EUS FNA. This we did with cholangioscopy. This is a compilation of data of EUS-guided FNA for biliary strictures, and you can see here it's an overall sensitivity of about 85%. So the bottom line is all comers taken for biliary strictures, EUS is fairly good. We then look at the impact of an EUS first kind of strategy. So the strategy that I just presented, we now submit to a scientific protocol. This was published in GI Endoscopy in 2013. So 40 consecutive patients. The primary aim was to look at the impact of EUS with FNA before cholangioscopy in biliary strictures. And again, the method was EUS first and then cholangioscopy for failures. And you can see here that in these 40 cases, EUS identified the area of stricturing in almost all of those patients, in 39 out of 40. FNA was achievable, however, only in 75%. So we were able to technically do FNA in only 3/4 of those patients. The FNA provided histocytology in 23 patients. So now we're down to 60% of those patients were obtained by EUS FNA. And when cholangioscopy was applied, in the 17 patients with either non-diagnostic or with autoimmune pancreatitis as the call by EUS, cholangioscopy was successful in 18 out of 19, so 95%. So it provided a tissue diagnosis in 16 with 2 false negatives. So going on with the results of this study, EUS prior to cholangioscopy avoided 24 cholangioscopy examinations. Secondly, the cost savings realized for these 40 patients in our US dollars was $110,000. And then ultimately, with this algorithm, we were able to get a tissue diagnosis in 94% of patients. So the take-home points for this talk about diagnosis of cholangiocarcinoma, I think I would recommend to you that you use an EUS, followed, if necessary, by a ERCP cholangioscopy guided biopsy, preferably with Rowe's algorithm as the best approach to these patients. And if you do use ERCP, if it's ERCP alone, then based upon the existing data, we would recommend that you do a multimodality technique, that you not just brush, but you do brush biopsies and perhaps even augment that with other studies as well. So with that, I'll conclude. Again, I welcome you to Orlando in late August if you are able to come and join us. And always a thanks to my unit for their support, and which allows me to come to Dusseldorf and enjoy this very great meeting. So, Fritz, thank you very much.